This is Kristen, Brittany, and Lita, and we are here to talk to you about ulnar transposition surgery. Ulnar nerve entrapment, or cubital tunnel syndrome, is one of the most common entrapment neuropathies in the upper extremity, second to median nerve entrapment at the carpal tunnel in the wrist. To understand the mechanism of injury to this nerve, please review its anatomical origin and path through the upper extremity as described on this slide. Now let's take a closer look at the pathology associated with this area. According to Posner, the ulnar nerve is compressed at 5 potential areas around the elbow. The ones highlighted in red are the most common sites. First, the ulnar nerve can be impinged within the intramuscular septa, resulting in neuritis. This can occur either at the medial intramuscular septum, through which the nerve pierces to reach the olecranon groove, or due to hypertrophy or malformation of the triceps muscle, where the tendon chronically snaps over the medial epicondyle and hits the ulnar nerve. Secondly, the ulnar nerve can be damaged by a valgus deformity of the medial epicondyle, resulting in an increased carrying angle at the elbow. This especially occurs with malunion after a condylar fracture or an epiphyseal injury to the lateral elbow, which causes ulnar nerve palsy, secondary to chronic stretching of the ulnar nerve. Thirdly, the ulnar nerve can be damaged due to chronic subluxation out of the fibro-osseous tunnel holding the ulnar nerve down at the olecranon. This occurs with a congenitally shallow epicondylar groove or a torn fibrous roof, allowing the nerve to chronically dislocate, causing neuritis and palsy. Fourthly, compression can occur at the cubital tunnel between the two heads of the flexor carpi ulnaris muscle, which flexes the wrist. The fibroaponeurotic covering of the epicondylar groove, or Osborn ligament, connects the two heads of the muscle. When the muscle is activated and tenses, the tunnel flattens, causing pressure on the ulnar nerve, resulting in pathology with repetition and overuse. Finally, as the ulnar nerve exits the flexor carpi ulnaris muscle, it perforates the fascial layer between the flexor digitorum profundus and superficialis, which is called the flexor pronator aponeurosis. The ulnar nerve can become entrapped at this site with excessive tensioning of the connective tissue. The most common mechanisms of injury that occur to the sites just mentioned are listed on this slide. Remember the anatomical origin and path of the ulnar nerve through the arm. Any lesion along this route or to any of its surrounding structures can cause similar symptoms. Pancoast tumor is a mass in the apex of the lung, which is positioned just anterior to the C8 and T1 nerve roots, which, as you remember, is the origin of the ulnar nerve. As the tumor grows in size, it begins to impinge on the nerve roots, resulting in ulnar nerve signs and symptoms. This condition can be ruled out by a cancer screen and/or imaging if indicated. Radiculopathy of the C8 and T1 nerve roots can be ruled out with Sperling's test, and brachial plexus lesions ruled out by tilting the head away with the shoulder anchored down. Refer for imaging if either test is positive. One of the most common differential diagnoses of ulnar nerve entrapment at the elbow is ulnar nerve compression in Guillaume's canal at the wrist. If sensation is present in the palm, then Guillaume's canal is implicated, since the sensory branch of the ulnar nerve to the palm branches off proximal to the wrist and is therefore spared. If the injury is more proximal, i.e. at the elbow, sensation in the palm is not spared, therefore implicating any of the 5 sites about the elbow discussed earlier. A patient with ulnar nerve pathology will have all of the symptoms listed on this slide, as well as a positive flexion test. The flexion test places the ulnar nerve on tension by depressing and externally rotating the shoulder, bending the elbow, and extending the wrist and fingers back. This position is held for 60 seconds and is considered positive if this position elicits patient signs or symptoms at any point during the test. This slide describes other complaints your patient may describe. Patients with ulnar nerve entrapment should be treated conservatively before referral to a surgeon as outlined on this slide. Conservative treatment should be carried out for 6 to 12 weeks and is most effective when the patient experiences symptoms of paresthesia that are transient, caused by malposition of the elbow, or from an acute mechanism such as blunt force trauma. If the patient's symptoms did not respond to the 6 to 12 weeks of conservative management, the patient may be a candidate for surgery. This is true especially if the ulnar palsy or muscle paralysis has progressively worsened, or if the patient is experiencing significant muscle wasting and/or clawing of the 4th and 5th digits.
The surgical procedure includes transferring the nerve anteriorly to lengthen the nerve and decrease tension during flexion. The nerve can be transposed under the skin, within the muscle, or above the muscle. Jadou et al. Conducted a study investigating whether subcutaneous or submuscular was more beneficial. They found good to excellent results in 92% of those in the subcutaneous ulnar nerve transposition group and 62% in the submuscular group. There was a greater incidence of poorer outcomes in the submuscular group of 38% when compared to the subcutaneous of only 8%. Primary outcomes included incision length, operative time, post-op pain, and complications. The secondary outcome was assessed at 12 months and they utilized the Bishop rating scale. Here is a table explaining the difference in the two procedures which were the main outcomes of this study. These outcomes were graded by the Bishop rating scale, which included ratings of excellent, good, or poor. This chart explains that the subcutaneous ulnar nerve transposition group was associated with excellent to good results 7.5 times more than the submuscular procedure. The procedure included an incision to visualize the nerve, an incision of surrounding structures to free the nerve, and all of those are listed below, and then they would reposition the nerve beneath the subcutaneous tissue. Before the procedure, the patient will wear a splint at the elbow in about 45 degrees of flexion for 2 weeks, preventing further injury. They will then be given instruction and a review of the post-op plan.
So as far as post-op rehab protocols goes, there's a general consistency of splinting for around 2 to 8 weeks, followed by a general promotion of range of motion and strengthening. There's a rehab protocol by Andrews et al. That suggests a series of 4 phases. So in the first and second phases, you're going to look mostly at immobilizing the elbow and getting partial range of motion gains. In phase 3, you're going to look at getting full range of motion and strength, and in phase 4, you're going to look at returning to full activity in sport. So here we'll take a closer look at the protocol. This is looking at phase 1, which is going to be within weeks 1 through 3. You'll see the goals of this phase is mainly to control edema and pain, protecting that surgical site, minimizing the deconditioning due to disuse of the upper extremity, and then increasing the passive elbow range of motion. Here are some of the interventions in phase 1. Take a second to look at these. Important to note that isn't listed under these interventions is actually doing nerve glides to that ulnar nerve, and that can be done as early as phase 1. So moving on to phase 2, still immobilized within weeks 4 to 8. Some of the goals under phase 2 include getting active range of motion. We want to get back that 145 degrees of elbow flexion, continue to protect the surgical site, and then increase upper quarter strength. Once again, here are some of the interventions listed in phase 2. Please take a second to look at these. Moving on to phase 3, weeks 9 to 13, no longer immobilized here, so full range of motion is indicated in a pain-free range, and that includes all activities. Continuing to increase strength throughout this protocol, and then returning to sport-specific activities if that is indicated. In this slide, you'll see phase 3 interventions. Please take a second to look over these. Here's phase 4, weeks 14 to 26. Really looking here at return to unrestricted sport activity if that's indicated for your patient. You're going to continue the intervention strategies listed in phase 3. So overall, you're looking at a total of around 6 months of rehab if you're returning to sports. Most likely going to be less for those patients that aren't, competitive athletes, but this protocol suggests 6 months if they return to sport. So prognosis for these patients you'll see is good. There's an 88% rate of good to excellent results. There's an average limited work capacity of around 4.8 months. Now that was seen in a military population, so in the average population you'll notice that will be less. So there's a range of around 3 to 7 months to return to work. So as with any surgery, there's a risk of infection or anesthesia-related complications. More specifically with these patients, there's a risk of ulnar nerve damage or a painful neuroma due to mechanical compromise or vascular compromise. Research shows that within 3 days post-op in these patients, there's very little vascularity to these structures, so hence the vascular compromise.
This slide summarizes some recent research regarding the various techniques utilized during ulnar nerve transposition surgery. Basically, the surgeon has 2 options, decompression or transposition. Decompression involves alteration of the surrounding bony and soft tissue structures around the nerve to create more area instead of moving the nerve itself out of the compressed area. Research shows that although there is not typically a significant difference in outcome between the 2 procedures, decompression is sometimes still preferred since it is simpler and less invasive. However, when transposition surgery is performed, the procedure is more successful with subcutaneous rather than submuscular techniques and can have better long-term outcomes than decompression surgery.
So the clinical bottom line here is that for those who do not respond well to conservative treatment within the first 6 to 12 weeks, ulnar nerve transposition is a favorable option with a high rate of excellent results. Here are the references used in this presentation, and we hope you enjoyed it.